Welcome to Books for Success. Today, we're delving into the wisdom within I Hate You, Don't Leave Me, by Jerold J. Kreisman, MD, and Hal Strauss. I Hate You, Don't Leave Me is an engaging introduction to borderline personality disorder, which explains how borderlines feel, who they are, how they behave, and how best to respond to them. A borderline personality disorder is an illness that terrifies many professionals and confuses the general public. Dr. Jerold Kreisman is a psychiatrist and an author, and Hal Strauss is a professional health and medical writer. They explain how people with borderline personality disorder, BPD, are impulsive, have wild mood swings, and troubled interpersonal relationships but get better over time with proper treatment. The lifetime prevalence rate of borderline personality disorder receives less than 2% of the money allocated by the National Institute of Mental Health, NIMH, to the study of disorders. Before we begin, subscribe and ring the bell for notifications if you want to keep receiving the knowledge of book summaries about health, wealth, love, psychology, and much more. Don't be shy about dropping your book suggestions for us to summarize. Also, you can use this video as an audiobook summary. Let's grow and succeed together. Borderline personality disorder is difficult to diagnose for the doctor and impossible to explain to a patient. It is to psychiatry what the virus is to general medicine. The term borderline was first coined in the 1930s, but the condition was not clearly defined until the 1970s. Psychiatrists have not been able to agree on the separate existence of the syndrome, much less on the specific symptoms necessary for diagnosis. In 1980, the American Psychiatric Association's third edition of the Diagnostic and Statistical Manual of Mental Disorders, DSM-3, the Diagnostic Bible of the psychiatric profession, defined the diagnosis of borderline personality disorder. It officially recognized the disorder as a significant health problem in America today, despite the discrepancies among psychiatrists over the exact nature, causes, and treatment. BPD patients consume a higher percentage of mental health services than those with other diagnoses. Also, about 90% of patients with the BPD diagnosis share at least one primary psychiatric diagnosis. A borderline person could be a friend who accuses you of stabbing them in the back over a minor fallout, tells you that you were never really her friend, and then calls back weeks later as if nothing happened. Inconsistency is the hallmark of borderlines and explains why the mental health profession has had such difficulty defining a uniform set of criteria for the illness. Borderlines are walking paradoxes. They have self-destructive tendencies or display suicidal gestures. Up to 70% of BPD patients attempt suicide. The most recent DSM-IV trail lists 9 categorical criteria for BPD, 5 of which must be present for the diagnosis. 1. Frantic efforts to avoid real or imagined abandonment. 2. Lack of clear sense of identity. 3. Unstable and intense interpersonal relationships. 4. Impulsiveness in potentially self-damaging behaviors, such as shoplifting, sex, substance abuse, reckless driving, and so on. 5. Recurrent suicidal threats or gestures or self-mutilating behaviors. 6. Chronic feelings of emptiness. 7. Frequent and inappropriate displays of anger. 8. Feelings of paranoia for a short period due to stress. Treatment focuses on 4 primary areas depending on the combination of symptoms presented. Those areas are: 1. Mood instability. 2. Impulsivity and dangerous uncontrolled behavior. 3. Interpersonal psychopathology. 4. Distortions of thought and perception. This summary identifies the symptoms and treatment procedures for BPD. Friends and families of a person suffering from BPD will also discover how to be a support system to them without causing more havoc. Treating BPD patients requires you to identify the disorder. An individual personality is a combination of temperament, inherited personal characteristics, and character, developmental values emerging from environment and life experiences. Take a look at Carrie, a social worker in the psychiatric unit of a large hospital who was diagnosed with borderline syndrome after 22 years of therapy and medications. Her disorder made her cut off everyone, forcing her into extreme loneliness. At some point, she began to wonder if she was possessed by the devil. Her experience reveals that correctly detecting the illness is the primary difficulty psychiatrists face. Often, it is mistaken for some other mental illness, which determines the treatment procedure they pursue. The wrong diagnosis resulting in improper treatment complicates the disorder. A borderline personality disorder may result from a collision of genes with the environment. The character slowly emerges as a child grows into adulthood, and their encounters with the world shape their character. Generally, there are two major groups of disorders: state disorders and trait disorders. The former can be treated with medication because they primarily relate to chemical imbalances, which medication can correct. Trait disorders relate to personality, and meds may not be a suitable treatment. Borderline is a personality disorder that hides behind state disorders. Thus, it doesn't readily come to mind until after eliminating state disorders presenting as symptoms. Borderline personality disorder can mimic other conditions, resulting in the patient being erroneously diagnosed with schizophrenia, anxiety, bipolar disease, attention deficit, hyperactivity disorder, ADHD, or other illnesses. Do you know? According to the NIMH, the rate of completed suicide in borderlines is almost 1,000 times the rate in the general population. Several generations contribute to the development of the borderline syndrome. The genealogy of borderline personality disorder comes with profound and long-lasting problems, including drug abuse, violence, loneliness, suicide, and incest. This poses questions on how borderline traits pass down through generations or if they pass down at all. There are two major theories on the causes of borderline personality disorder. One emphasizes developmental, psychological roots, while the other attributes them to biological and genetic origins. Much like the nature-nurture controversy, there is a dilemma on whether to blame temperament, nature, or character, nurture. However, it is important to consider a third theoretical category: environmental and socio-cultural factors. These factors include our fast-paced, fragmented societal structure, the destruction of the nuclear family, increased divorce rates, greater geographical mobility, and changing patterns of gender roles. Through the little empirical research on these factors, some professionals speculate that they would increase the prevalence of borderline personality disorder. Also, the available evidence points to a combination of genetic, developmental, neurological, and social factors as contributors to the development of BPD. Dysfunction in the brain's 7 main neurotransmitters is associated with impulsivity, mood disorders, and other characteristics of borderline personality disorder. The frequent abuse of food, alcohol, and drugs is typically interpreted as self-destructive behavior and may also be an attempt to self-medicate to heal inner emotional turmoil. It dulls the internal pain and releases hormones that mimic the experience users get from narcotics. Development theories on the causes of BPD focus on early childhood. The interactions between children ages 18 to 30 months and caregivers play a significant role in the type of adult the child becomes. This period is when the child begins the struggle to gain autonomy. While some parents offer a controlled, exclusive, often suffocating symbiosis, other parents offer only erratic parenting during much of the child-raising period and fail to provide sufficient attention to and validation for the child's feelings and experiences. These extreme parental behaviors, over-control and lack of emotional involvement, can result in the child's failure to develop a positive, stable sense of self and may often lead to the constant need for attachment and chronic fears of abandonment. Society, parents, and institutions play a significant role in the life of an individual. The culture and prevailing living standards at any given time determine how psychological theories are perceived. Social factors interact with borderline personality disorder in several ways, and we should not overlook them. If borderline pathology originates early in life, as evidence indicates, changing social patterns of family structure and parent-child interaction are more likely to increase pathology. Also, social changes of a more general nature have an exacerbated effect on people already suffering from borderline syndrome. The way of life modern man has embraced has invariably made personality disorders more pronounced, specifically BPD. Families, friends, and therapists of the borderline can learn to communicate with them using the setup system. When communicating with people with borderline personality disorder in crises, you should apply the setup system. Three feelings or states are characterized as internal force fields that hinder communications during times of terrifying loneliness, feeling misunderstood, and overwhelming helplessness. As a result of these hindrances, caregivers find it easy to lose their cool when dealing with the demands of borderlines. UP stands for understanding and perseverance, which are the goals that all parties try to achieve. Support is the first stage of setup. It involves invoking a personal support statement. I am sincerely worried about how you are feeling. During this stage, the emphasis is on the speaker's feelings and is essentially a personal pledge to try to be of help. Empathy, the second stage, is about acknowledging the borderline's chaotic feelings with a you statement. How awful you must be feeling. The emphasis should be on the borderline's painful experience, and the speaker should neutrally express it with minimal reference to their own feelings. The third stage, truth or reality, emphasizes that the borderline is ultimately accountable for his own life and that others who attempt to help cannot displace this primary responsibility. Truth statements acknowledge that a problem exists and address practical, objective issues of how to solve it. The truth part of the set is the most critical and complex for the borderline to accept. If the self-statement of support is missing, the borderline assumes that you don't care. Also, if you don't communicate the empathy component clearly, the borderline assumes you don't care about how they feel. Note that productive communication requires understanding and perseverance. Understanding the dynamics of communication and needs reinforces set principles. Perseverance is necessary to effect change. Identifying a borderline is vital to interacting with them successfully as friends or relations. Despite the underlying volcanic turbulence, borderline personality disorder can be complicated to identify on the surface. Unlike many people afflicted with other mental disorders such as schizophrenia, bipolar, manic depressive disease, alcoholism, or eating disorders, the borderline can usually function exceptionally well in work and social situations without appearing pathological. Therefore, it is vital to note that borderline personality disorder is an illness, not a willful attempt to get attention. They need help and motivation to modify their behaviors. That is not to say they are not responsible for their conduct, but we must be aware of how our interactions may encourage or inhibit borderline behaviors. We must respond supportively without overacting. Setup techniques might help in dealing with and predicting impulsive behaviors from past experiences. By assisting the borderline in seeing their pattern of behavior, they can gain awareness of what triggers their impulsivity. Doing this with support and empathy will help the borderline learn that what they have perceived as chaotic and unpredictable can be anticipated, understood, and controlled. Therapists often find that the rigors of treating BPD place a tremendous strain on their abilities and patience. Borderlines can be highly demanding, dependent, and manipulative while in therapy. And some borderline patients drop out of therapy in the first few months. Treatment is challenging because borderlines respond to it the same way they do other personal relationships. According to the American Psychiatric Association's Guide for Treating a Patient with Borderline Personality Disorder, the primary step is psychotherapy, complemented by symptom-targeted pharmacotherapy. To get a patient to be less dependent on them, their therapist must direct the patient's attention to specific areas for examination, not control them. The primary objective is to allow the patient to be in the driver's seat and improve relationships at home. Often, the length of therapy depends on specific goals. For some borderlines, treatment never formally ends. As they strive to achieve independence, they may need continuous sessions with a trusted therapist. Psychotherapy can occur in individual, group, or family settings. The approaches differ from one therapist to another. Some opt for the psychodynamic approach, finding a link between the patient's past experiences and present behavior. They attempt to exhume the unconscious feelings experienced by the BPD. Another approach is the cognitive approach, where treatment is direct and emphasizes changing current behaviors instead of returning to the past or the unconscious. Therapists hardly opt for approaches that involve behavior modification or classical psychoanalysis because it may be too invasive for the borderline's primitive defenses. Social media and movies have portrayed therapy in a bad light and increased fear of it. Pop culture describes the shrink as someone who either needs the treatment more than their patients or is a criminal mastermind who manipulates patients for selfish goals. Healing from borderline syndrome requires conscious retraction from unhealthy situations and the will to build healthier foundations. Change entails coping with the drastic interruptions of a long-established equilibrium. Change is viewed as problematic because humans instinctively resist it. The uncertainty of change is even more threatening for the borderline because their world is about black and white parameters. So, change for the borderline involves more fine-tuning than total reconstruction. It is best initiated gradually, with only slight alterations at first, and must begin with self-assessment. A borderline personality is a series of intersecting lines that make up a spectrum. One side is self-sacrificing over concern, and the other is a don't give a damn personality. Actual change requires persistent practice. The borderline must be willing to take a step to overcome the menacing barricades mounted by splitting and lack of object constancy to initiate this change. They must learn to trust others, but in doing so, they must first trust their perception of others. Change requires the appreciation of others as independent people and the empathy to understand their struggles. The borderline must learn to establish a separate sense of identity and overcome the fear of merging with others. Conclusion. A personality disorder is a complicated disease to diagnose and is extremely difficult to treat. It requires the contribution and cooperation of the patient and their therapist, family, and friends. A combination of genetic and developmental factors provides insight into the roots of borderline syndrome. The disintegration of culture leading to the breakdown of structure and the creation of a fragmented society has ensured an increase in several borderline personality disorder cases. Dealing with borderline personality disorder requires cultural changes in how we live and organize our societies. The setup principles will equip those living with BPDs with the necessary skills to help them on their journey toward healing. The therapist must set the goal of seeing themselves as navigators rather than controllers of the borderline. They aim to point out landscapes of interest and help them reroute around the storm. Whatever approach the therapist employs, the ultimate goal is to help the borderline return home and improve relationships there rather than abandon them. The prevalence of BPD should teach us to be more humane in our interactions with others. Since most patients go undiagnosed, we can be kinder to those who display one or more of the disease's symptoms. Try this. Using setup principles helps people with personality disorders navigate the way back toward healing by providing the necessary support to overcome their problems. Is there a borderline in your life? Write out how you intend to apply this setup principle to help them gain balance. If you don't have a borderline in your life, the setup principle can prove effective in your daily communication and interactions. Thanks for being part of our insightful voyage. If our summary piqued your interest, we encourage you to dive into the complete book for a deeper understanding. Don't forget to like this video, subscribe for more content if you're new here, and share it with others who might find it valuable. Keep on reading, discovering, and advancing until our next adventure.